Hello everyone, I'm Dr. Manish Nagpal and we're doing these modules on macular hole surgery. Harvey has done the first module explaining all the rationale for what macular hole is and what are the steps taken to close the macular hole. And I'll just take you over through the surgical steps at this stage. The first step is doing mainly the vitrectomy, which creates a space for creating a tamponade and also removing the peripheral traction. The second step is to do a posterior vitreous detachment, in which we relieve the anterior traction. After that, any epiretinal membrane or internal limiting membrane is peeled, and then a tamponade is put. Apart from that, some adjunctive steps are done depending on the complexity of the situation. The first step is to do a PVD creation, as you'll see in this video. We have stained the hyaloid with triamcinolone and it forms these beautiful two halos around the macular area. After that, we use a high suction to remove that hyaloid from its attachments, and you can see that the whole hyaloid sheet moves up. This whole sheet is removed using the cutter. This is the first and the most crucial step to remove the traction from the macular hole. After this, a staining is done so that we can remove the ILM. After that, you can see the stain well taken. And then with a pinch and peel technique, using a forceps, I'm peeling the ILM in a circumferential manner. I peel about 1.5 to 2 disc diameters. You can see that I'm enlarging it at this stage. And then there's a sufficient 2.5 disc diameters of a peel all around the hole. At times, instead of doing a pinch and peel, one can also use a finesse loop to have a very nice initial hooking of that, seeing the flap. The finesse loop has a serrated surface which, if you move gently over the surface of the retina, can create a very nice flap without traumatizing the retina. This is the finesse loop, and you can see that I am gently brushing it over the retinal surface in order to create a flap. So as we rub against the retina, it does not traumatize it because the serrations are very fine. And then you have a flap which is created. After this, you pick up the forceps, flap with the forceps, and then go circumferentially all around it, just like I did in the previous case. Make a nice round island flap and then enlarge it. The finesse loop is very useful for cases of high myopia where the camouflage of the choroid and the visibility is not that great. The finesse loop is much more useful there. Moreover, we have designed a tool we call the massager. It is a 25 gauge miniature replica of an external indenter that you see here. So we use it just after doing the island flap. As soon as the flap is removed, then we use this massager with which we gently massage circumferentially all 360 degrees so as to approximate the edges of the macular hole. This basically relieves a bit of a contraction which most of these holes have over a period of time. And this is very gentle and non-traumatic. Once this is done, we do an air fluid exchange. And as you can see that the fluid exchange is getting over and you see a pinpoint area. The hole has reduced to a pinpoint and almost closes on table. Now this is a case of a vitreomacular traction, or what we call a grade 1B macular hole. Here the strategy is a little different. That's because there is a vitreomacular traction and the hole has not yet formed, and you don't want to have de-roofing of the vitreomacular traction area. You don't want to cause a hole form just because you create a PVD. So you have to be very gentle here. You do the same staining. You create a halo of the triamcinolone stained hyaloid, but you will not pull all the way like we did with the previous cases. So we gently trim all the peripheral parts of the stained hyaloid so that the central part is separated from the peripheral part and the traction is not applied from the periphery. Once that is done, I use a magnified view, and you can see here the central small sheaf of vitreous which is still attached to the fovea, and we very gently cut off all the peripheral part, trim it, and just leave a small little area of the attachment without pulling at it. So you can see that very fine attachment as a pinpoint over the fovea. Now, if you pull at it, you could deroof it. So the trick is either you trim it with a cutter and leave it, or you remove an ILM, just like I'm doing right now, and that area comes off with the ILM. And this is less traumatic and is less likely to cause a deroofing of that area. So this is something one must do if you are dealing with a stage 1B hole or a vitreomacular traction, and not just pull at the hyaloid like we do for regular macular holes. And after that, the steps are the same. Now, this is a case of a patient who developed a macular hole almost 10 years after a buckling surgery done for retinal detachment in the past. You can see the cryo marks in the periphery and the demarcation area which was seen of the previous detachment. The hole has recently formed, so we have stained the hyaloid the same way as we did with the previous cases, removed the hyaloid, and after that, now we are looking at the stained area. In fact, you can see that the central area has not taken a good stain because there is an epiretinal membrane there. So we first remove that epiretinal membrane, and you can see that there is a strong adhesion in the central part where the hole is lost. So we just leave it at that area instead of pulling at it, and then go ahead and remove the ILM from the periphery. Because here, once again, we don't want to pull at the central area of the hole because of that adhesion. So we'll just enlarge the peel using the ILM instead of that epiretinal membrane. By a pinch and peel technique, I'm just enlarging that area, as you can see now. And along with it, we segregate the central area from the peripheral area which is connected to the ILM. So all these macular holes have slightly different variations, and now at the end I've just trimmed it with a cutter instead of pulling at it. And then use the massager the same way as I showed you in one of the previous cases to approximate the edges. This gently relieves the contraction 360 degrees without traumatizing the retina. And once this maneuver is over, we do the same air fluid exchange, and as we finish the exchange, you'll see the hole reducing to almost a small pinpoint size and closes on table. So at the end of these surgeries, usually a tamponade is used in the form of either an air or a gas, which could be an SF6 or C3F8, which varies with different surgeons based on their experience. The objective is to apply surface tension to allow absorption of the subretinal fluid and promote the macular hole closure. These gases stay for 2 to 3 weeks, and we give prone positioning to the patient so that they can keep the area of the macular hole dry while it closes and approximates very well. So these were some of the classic cases of macular hole surgery, all the steps of PVD creation to ILM peeling, and then doing an air fluid exchange followed with a tamponade that is classically used for macular hole surgery. Our next module will deal with more complex cases of macular holes, and which I and my colleague Dr. Harvey would show some different examples of cases. Thank you very much.